Hello everyone. The purpose of our presentation today is to present a podiatric case study where obesity has played a significant role in the development of plantar fasciitis for a 48-year-old male patient named Peter. Over the last 2 months, Peter has been experiencing mild plantar heel pain, which was first noticeable when he got out of the truck one day to get food. Due to the severity of his heel pain increasing substantially within the last 7 days, he has decided to seek treatment as he finds the pain unbearable and limiting his ability to ambulate. His occupation consists of truck driving and as a result lives a highly frequently sedentary lifestyle. He is also a regular smoker and his weekly diet primarily consists of fast food and convenience foods at service stations. Peter's chief complaint is bilateral chronic plantar heel pain, but asserts that the pain eventually subsides within 20 to 30 minutes of walking. In addition, Peter has also noticed that his heel pain reoccurs after being sedentary for long periods of time, for example, getting out of the truck to go for a walk to get food. An insight into Peter's relevant medical history reveals a family history of type 2 diabetes, hypertension, and hypercholesterolemia. He is managing his diabetes by taking metformin and his hypercholesterolemia by taking atorvastatin. Furthermore, he has previously had stress fractures of the second and third metatarsophalangeal joints and worn custom-made orthotics 10 years ago to treat a mild diagnosis of plantar fasciitis. Careful clinical examination of Peter's signs and symptoms resulted in a provisional diagnosis of plantar fasciitis, as this tends to be the most common cause of chronic plantar heel pain. Additionally, his post-static dyskinesia is also an indication for disease and tendinopathy. To confirm the diagnosis, he was referred for an ultrasound to identify the source of the pain, as sonographic evaluation easily shows the characteristic pathologic changes. Upon his return, the results of the ultrasound tested positive for plantar fasciitis. Now that we have confirmed the diagnosis, the relevant anatomy of the structures involved must be addressed to provide appropriate treatment and management. Plantar fasciitis can be defined as a chronic inflammatory and degenerative irritation at the insertion of the plantar fascia on the medial process of the calcaneal tuberosity. In finer detail, the plantar fascia is a thickened fibrous aponeurosis originating from the medial tubercle of the calcaneus, running distally to insert into the deep and short transverse ligaments of the metatarsal heads. It then divides into 5 digital bands at the metatarsophalangeal joints to continue forward to form the fibrous flexor sheaths on the plantar aspect of the toes. In normal circumstances, the plantar fascia acts as a windlass mechanism to provide tension and support through the arch. Since the central band is the thickest and strongest section, it will most likely be involved with plantar fasciitis. Other relevant limb structures which are considered risk factors include tightness in the hamstrings, gastrocnemius, soleus, and the Achilles tendon. With regard to the causative factors for obesity, there are a range of environmental and genetic factors that predispose individuals to disease. For instance, during the hunter-gatherer days, where an individual's primary goal was to find food, a large proportion of physical exercise and energy was expended. Therefore, it makes intuitive sense that as food becomes more accessible and the process to obtain it becomes easier than ever before, increase in food consumption will soon follow after. This statement is supported by the Australian Institute for Health and Welfare, as 63% of individuals 18 years and above were considered to be overweight or obese. Furthermore, although weight gain is primarily associated with cumulative energy intake exceeding energy expenditure, it can be argued that there is a complex interplay of genetic, physiological, and social factors that have also influenced towards disease. For instance, as the environment today is heavily influenced with marketing of fast foods, the conscious decision to overindulge can be considered a social influence. For example, alcohol consumption is increasing, with the Australian Bureau of Statistics recording an average consumption of 2.1 standard drinks per day for individuals 15 years and above. In another sense, imbalances in hormones such as insulin and leptin have been demonstrated to be genetic factors influencing metabolism and fat distribution. Likewise, cardiovascular disease and eating disorders are also other determinants which play an important role in the pathogenesis of obesity. As we can now understand that obesity is multifactorial, it is appropriate to discuss its influence on the pathogenesis of musculoskeletal conditions of the lower limb, such as plantar fasciitis.
Obesity has been hypothesized to alter foot function and structure via three key mechanisms. These include abnormal arch function, reduced elasticity of the plantar fat pads, and increasing plantar pressures. Firstly, abnormal arch structure and movement have been implicated in the development of plantar fasciitis and subsequent heel pain. Pes planus foot types resulting in a lowered medial longitudinal arch and abnormal lower limb biomechanics such as excessive foot pronation have been demonstrated to increase tension within the plantar fascia, leading to high risk of fascial injury. Yet it is important to note that scientific support for the role of altered arch mechanics is at best equivocal. Secondly, it appears that obesity changes the physical and mechanical properties of the subcalcaneal fat pad to influence the development of plantar fasciitis. In one perspective, high levels of fats in the blood may lead to a greater quantity or viscosity of adipose tissue contained within the U-shaped septae of the fat pad. Consequently, this increases stiffness and reduces the elasticity and compressibility of the fat pad, which lowers the attenuation of impulsive transients during gait. Yet, this evidence may also be equivocal, as other studies have found the opposite effect, that obesity is associated with a thinner, unloaded heel pad and higher compressibility index leading to plantar heel pain. Last of all, increased weight has been shown to increase plantar pressures in both men and women and be associated with heel pain. Other obesity factors such as increased leg swing velocity, high metabolic expenditure, and decreased postural stability may also alter foot function by changing lower limb gait patterns and produce variations in muscle activity to increase the risk of musculoskeletal overuse injuries. On a more interesting note, although it is likely that chronic plantar heel pain develops in response to obesity, it is also possible that obesity develops as a result of decreased physical activity subsequent to chronic plantar heel pain. The key podiatric management goals relevant to Peter's case include reducing his experience of heel pain, improving his mobility, and returning him to his normal activity levels. Due to the strong evidence that intentional weight loss and weight maintenance reduces the burden of obesity-related comorbid diseases, it can be said that treatment for Peter should predominantly aim to reduce his excessive weight. This would reduce the mechanical loading and excessive tensile strain within the plantar fascia to allow for adequate healing. According to Obesity Australia, the employment of educational, personal, medical, and environmental interventions are effective ways of reducing obesity. The first step is to offer hope to Peter that a loss of only 5 to 10% of initial weight may significantly improve his condition. Since excess weight is a highly sensitive subject, it is a requirement for podiatrists to provide a supportive and non-judgmental environment to facilitate patient compliance and long-term success of treatment. In order to achieve weight loss, Peter can undertake personal lifestyle modifications involving a transition into low-fat, carbohydrate, and meal replacement diets to restrict fat and calorie intake. Additionally, other behavioral changes include goal setting, increasing physical activity, reading food labels, eating smaller portions, reducing job stress, and getting approximately 6 to 9 hours of sleep at night. Medical interventions such as pharmacotherapy are typically indicated if the body mass index is greater than 30 kilograms per meter squared, and surgical procedures such as bariatric surgery are generally indicated if the body mass index is greater than 40 kilogram meters per squared. According to Tsai and Wadden, bariatric surgery is one of the most efficacious treatments for severe obesity, as dramatic weight loss often ameliorates comorbid conditions. Lastly, as change in social and physical environments such as reformulation, labeling, and an introduction of a tax on unhealthy foods can also facilitate weight loss. That concludes our presentation. Thank you for your attention.